Welcome to the next episode of Mic'd Up with Chirop. I'm your host, Brandon Steele, and today we're going to go through a couple fun things. This is going to be a touch longer of a podcast, but I assure you it's going to be jam-packed of evidence and practical things you can use in your practice. It all stemmed from an email that I got from Mark King. Mark King is the president of MPI. And he always gives me these little tidbits, these quotes or pieces of clinical gold or business ideas to think about from the people in his network from Motion Palpation Institute. And I received this email and I want to rehash it and how this one email turned into a podcast. Well, this email was about a case study, and it talked about a study of 65 male youth baseball players. And they found that people that had greater internal and external rotation strength had less arm pain. And they found no other correlations between range of motion, strength ratios, any kind of height or BMI ratios, or anything that had to do with does this person have shoulder pain or not, besides do they have more or less strength and internal and external rotation strength. And it was a great paper, so there's nothing wrong with the paper, but I thought to myself, what if it was just that easy? Like, what if you just had to pick the one thing that you need to improve to get the most patients well? For every patient with plantar fasciitis, you did this exercise. For every patient with shoulder impingement syndrome, you eliminated this sleeping posture, whatever it may be. And what if there was just one or two things that we had to do to help resolve the vast majority of pain for the patients we see? And I'm not talking about the latest NASA proven technology that fixes everything. I'm not talking about the one treatment that fixes every orthopedic diagnosis or the 7 steps to treat every knee pain patient. I'm talking about what if we, as evidence based chiropractors, took an evidence based approach to the physical and orthopedic exam, and then we were able to select what we think is limiting this person from getting better and fixing that, and then found things to speed up healing to get this person out of the problem. Too often we try to diagnose patients and then provide whatever treatments we think the patient needs. But what if the patient already told us what they need? What if it's the way they're sleeping? What if it's their job? What if it's the way they're walking? Are we attacking that? Are we giving the patient the right information to help them heal quickly? So that's what today's podcast is going to be on, healing. Now, the body has to heal itself. You and I know that. However, what are the modifiable risk factors that slow down the healing time of tissue? It's the first thing we're going to cover. Secondly, conversely, I guess, we could say that as evidence-based chiropractors, what can we do to speed up the healing time? This is the more intriguing thing. I'm going to use research from 2023 and 2024 to explain all the things you can do as a provider to help speed up that healing time. And then I'm going to cover a new type of treatment that's going to possibly affect how you treat your next patient with myofascial pain. And then finally, a little fun. We're going to play the name game, essentially. Each and every one of you play this. I play this all day long. It's where the patient's first name actually determines how long it's going to take to treat them, how often you're going to have to treat them, what you're going to have to treat on them, and the treatment types. And I'll explain that at the very end of the podcast, but it is my favorite thing to do in practice. So buckle up, let's go. As always, if you like these episodes, please share it. We're trying to help more chiropractors understand how to use simple, evidence-based strategies to improve their clinical success and, of course, improve their business P&L. If we do a great job, we deserve to get paid for doing that great job. And I'm going to give you some resources to make that a little bit easier. So, what are the things that can slow down healing? Actually, cryotherapy, reduced blood flow, lack of sleep, lack of movement, and actually fear of movement. So, I'm going to go over some research on how to assess those and fix those. And then, what are the 8 things that can actually speed up healing? We're going to go over patient education, when to rest them, how to brace them, how to regain full range of motion of that tissue. We're going to talk a little about passive modalities and how to get that person into activity quickly, and then how to progressively load them. And if things are failing or not moving along fast enough, what kind of injections are actually at our disposal to help these patients? So first off, let's drive into the factors that limit healing. Now, this may be counterintuitive, and this is actually against my, I'm going to say my upbringing. What I've always learned as a kid who played sports is that cryotherapy may limit tissue healing. The reason I bring that up is Dr. Bertelsmann actually just put out a blog last week, and it talks about heat versus ice. If you have not read that blog article, I assure you it will change the way you think about passive modalities. I'll include a link in the description in this podcast also. But here's the nuts and the bolts behind this. In fact, the British Sports Journal of Medicine 2024 said is that pending the results of human studies, cryotherapy may be recommended in the first 6 hours, may be recommended in the first 6 hours, and that can reduce the swelling, reduce some pain. But really, after 12 hours, it actually interferes with tissue healing and regeneration. You heard that correctly. You can ice at the very beginning, but after that, no ice or really heat. That is a big piece of the puzzle when you have patients coming in. Oh, well, I ice and heat, every single day, 12 times. That's a very compliant patient, just compliant in the wrong modality. Next, we're going to talk about gender and smoking. Listen, smoking is not great. We're not going to solve that problem. However, it really brings this thing to light is that blood flow is that whenever you have tissue that is trying to heal, things that limit blood flow, like obesity, like smoking, actually reduces tendon healing and degeneration. And there's a BMJ study in 2021 talking about body weight, and I'm sorry, about body weight, about women. And it said women have 21% more issues than men, 21% more diagnoses than men. And their thought process was that women have more issues than men. You and I know that's not the case. Uh, who is the first person you see in a family that walks in your door? It's almost always the wife. And then who do you see? You see the children. And then if you don't injure any of them, who do they drag in? The husband. Men just don't take as good a care of themselves as women do. Also, take into consideration, I just did a presentation on pediatric sports injuries. Young girls actually do get injuries more than boys. And one of the prevailing thought processes is that younger girls, when they're maturing faster and their growth plates are still open as they actually get taller. So they increase torque at those joints, especially the knees. That does predispose them to things like an ACL injury. Next, what's the next thing that actually may limit healing? Poor sleep. I'm telling you, sleep is a big thing. There was a paper in September 2024, Frontiers in Public Health, and what they found is that shorter sleep duration is a risk factor for lower back pain, and it's especially the older patients above 50. And it's not even like it's possibly correlated. They said an L-shaped association, meaning if you don't get at least 6.5 hours sleep, your risk of lower back pain sharply increases. This is a ginormous thing that we should be attacking as providers to make sure that our patients are sleeping. If they're not sleeping, they're not healing. Another study in Frontiers in Medicine said really we should be getting between 7 and 9 hours of sleep. And then if you're not getting at least 7 hours sleep, it's linked to higher prevalence of chronic musculoskeletal pain. We really need to be making that known with our patient population. I hinted on it earlier, and I want to bring this up today because I just had a patient this week talk about eating bacon and eggs every morning. He was just from a very young age, his bacon and eggs, meat and potatoes kind of kid. And there was a BMC paper that said that risk of chronic lower back pain increases with higher values of BMI in really both sexes. That unfortunately, as we eat foods that make us bigger, it will increase our pain and inability to heal. This kid, who is now a 75-year-old kid, was obese, and he had no idea that bacon and eggs every day for morning was bad for him. He's a 75-year-old man. However, he had been taught from a young age that those were good foods, and we see the same thing in our patient population: people drinking Diet Coke and eating poor food choices that are linked to their pain syndromes. And then finally, the last thing that I want to cover as far as things that slow down healing process is just flat out lack of motion. And what we know, lack of motion is not a good thing. One topic we've been covering a lot in Chiro is nerve flossing. And I did find a paper, it was in the European Journal of Physical Rehabilitation Medicine 2024, that said that even your patients who have significant problems that are requiring surgery, in this case for carpal tunnel syndrome, that just getting that tissue to move, in this case the nerve, will significantly decrease their pain and sensitivity associated with the diagnosis. So if we have patients with joint problems, muscle problems, nerve problems. It doesn't matter which one it is. We have to get that tissue moving. And if we don't, it progressively gets more sensitive, more painful, and it limits our ability to let that tissue heal. Now, a quick word from our sponsor.
Can't get enough of the information you hear on our podcast? You will absolutely love our platform. ChiroUp helps thousands of chiropractors across the globe simplify the way they practice using our online evidence-based software. It's your one-stop shop for powerful clinical research, simplified patient education, and smart practice resources. Visit chiroup.com, try it out for free. And if you'd like to subscribe, use referral code podcast15 for 15% off 12 monthly billing cycles. No contract required. Offer valid on new subscriptions only.
All right. Thanks for listening to that message from our sponsors. Now let's talk about the fun part. The fun part is, how do we speed up healing? Now, one of the things we can use to speed up healing, which sounds counterintuitive, is rest. However, I'm going to break this down as the evidence would and not call it total rest. We're going to call it active rest. And what that means is that we need tissue to calm down. And while rest is essential for healing, I get that, complete inactivity is actually counterproductive. We need to gradually, slowly reintroduce controlled movements to help promote blood flow, stimulate healing, and prevent stiffness with all of our patients. So I did find a paper. It was in the International Journal of Environmental Health and Research 2024, and all of these will be linked in the detail section. And it talks about something that I've actually never heard before. It's called green exercises improve chronic health issues. Green exercises. I had no idea what that meant. However, green exercises are exercises performed in natural settings. And I think this is so cool because one of the things that I have difficulty with is that when I have a patient who is, standing because they're a worker on the assembly line, or they have to sit all day long because they're in an office setting, I need to provide a way to get them to move in their natural setting. And as it turns out, whenever we can incorporate green exercises, and as long as it's safe, we can actually improve chronic health issues, mostly because it's probably that long-term posture they had when they're working that created their issue to begin with. If we can start to get them to move, we can get them a lot better. Now, I will say that they also talk about walking in this paper. Walking is one of the most safest, effective exercises that you can possibly do, as long as it doesn't cause sharp pain or shooting pain. So a new word, green exercises. Next is bracing. I'm not a huge fan of bracing. I like people to move. However, I will say this because the research does support this. In fact, the paper I'm going to talk about is in the British Medical Journal, but it talks about carpal tunnel syndrome. And it says, don't use a splint, use a splint, or use a splint with a metacarpophalangeal brace to not allow finger flexion. And what they found is that wrist splints that incorporate that metacarpophalangeal joint motion, but preventing the flexion of the fingers essentially, is more effective than a traditional brace and more effective than not wearing a brace at all. So if you're looking for long-lasting improvements with carpal tunnel syndrome, using the appropriate brace will help your patients heal faster. I will say a typical cock-up splint works also very well, but both these things work better than no splinting at all. If you have a patient who has carpal tunnel syndrome and you're not bracing them, you're not following the standard of care. Even if you don't carry that brace in your practice, there is a service, and I'm not sure of every single person in this, this podcast who we reach. However, there's a service, and I practice in Illinois. It's called Amazon, and Amazon will deliver anything to my door. And in fact, they'll deliver anything to your patient's door. So a great service to help find these splints, find an example, put the link in your ChiroUp condition report, and just say, hey, here's a brace you can pick up on Amazon. It'll be at your door tomorrow. It's going to help patients heal faster. Next, you and I know this. However, I'm going to put a little spin on this because this is something, I don't want to say it's a pet peeve, but it's something I hear on a regular basis. So the number 3 way to help someone heal up faster is to help them regain full range of motion. Now, you and I know that. We use manipulation, mobilization, stretching, whatever it is you use in your practice, keep on doing it, obviously. However, here's a thing that I hear in my practice that I want to bring light to and hopefully help you and your patients understand why it's not enough. Because people always tell me, and I do believe them, that I'm always moving. I'm always up and active. And let's talk about the hip. In fact, I have these somewhat memorized, is that people always say, if they have a hip problem, they go, I'm always up moving and I walk 3 miles a day. Well, don't quote me on the numbers here. However, the hip range of motion is about 150, 160 degrees in flexion is full range of motion flexion. 20 degrees extension, that's 100, 175 degrees of motion in one plane. So you have 170 degrees of range of motion in your hip in one plane. Well, what if you're just walking? What if you're just being active? Well, when you're just walking, you only get about 40 degrees of motion, the total flexion and extension of the hip with normal range of motion walking. Going up and down the steps is not much at all. Going up the steps, you get about 67 degrees of flexion. Down the steps is, I think, around 50 degrees, a little bit less. Squatting gets you the most flexion, but still you're only around 120 degrees. When you go from a sitting to a standing position, about 100 degrees. I mean, you're not getting full range of motion. The reason I remember those numbers, I have a presentation that I always do because getting on and off the toilet averages 110 degrees. I'll try to find those stats and put it in the details section of this podcast. However, even when we're doing our normal activities of daily living, it's not full range of motion. We need to get patients out of their comfort zone and explore those full ranges of motion if we're going to get them out of pain. And then why, you ask? Well, exercise stimulates nerve growth. There is research that says that as we contract muscle and as we do exercise, we release biochemical signals known as myokines, not cytokines, myokines. And these things play a powerful role in nerve growth. The study that I looked at was in Advanced Healthcare Materials. It was in 2024, and they looked at lab studies, and they found that neurons exposed to these muscle generating signals, these myokines, they extended their length actually 4 times further than the nerves that were not exposed to exercise. So just by getting exercise in, both biochemically and mechanical effects of these muscle contractions can help get this tissue to grow faster. And as we know, with our patients with nerve symptoms, nerves are sometimes the most difficult to get better. So, how else can we get things healing? Number four, we're going to talk about passive modalities. I'm not a huge passive modality kind of guy. We do have passive modalities in our clinic and we use them a lot. However, we have to know what we're doing and why we're using them, because there was a BMC study in musculoskeletal disorders and they talked about TENS units, and they talked about extracorporeal shockwave therapy and laser. And they found that these things actually do improve pain symptoms, joint mobility, psychological state. I mean, patients love getting heated up and electrocuted. Just it is what it is. It feels good. However, these things actually do a lot more than that. They can increase blood perfusion. When you get more blood perfusion, get more oxygen supply to those ischemic tissues and allow this tissue to not only heal, but also reduce pain. So using passive modalities is not the worst thing in the world. There's been this huge push in the evidence-based mindset that we need to be exercising everyone and doing deadlifts with everyone. However, a lot of our patients don't need to start there. They need to start with some passive modalities to start the healing process. And it all has to do with matching the treatment to what is going on with the patient. So most of our patients, that when we're trying to heal something, we need increased blood flow. So let's think about that. We need to increase blood flow if we have a tendinopathy, if tissue needs to start to get bigger and stronger, and we have to decrease blood flow if we have tissue that's inflamed. So when I have tissues that are going through a degenerative process in the tendon, I need to create a controlled inflammatory reaction. I'm going to use dry needling. I'm going to use a cross friction massage. I'm going to use a tool to scrape that tissue that's going to help break up some of the tendon adhesions, break up the layers of tissue, all those things that hinder tissue, tendon healing. So one of the things we need to do is speed up healing with increased blood flow, but we also need to do the exact opposite. There are patients that have tendinitis where they have high levels of inflammatory markers. And before we start a progressive loading program, we actually need that tissue to calm down. And the reason we don't always have to go into, progressive loading and deadlifts, because these patients, if they just injure themselves through a trauma, if they injure themselves through something they don't normally do, maybe they were doing some construction work they don't normally do for their life, then we just need to calm them down and send them on their way. We don't have to take someone through an extensive progressive loading program for every single patient, just the people that actually require it. Now, number six, return patients to activity as fast as possible. Now, remember this is that when we go into rehab, practice makes permanent. Practice does not make perfect. So if your patients start to do your exercises incorrectly, even if it's at low load, it's going to be a problem. So make sure that one, you educate your patients in your office on how to do the exercises, and then begin with low load and then progress. Chirop already does this for you with the phase one and phase two exercises and allows you to provide those exercises to your patients. So whatever exercise program you use, make sure you're speaking to a patient on their level. You're using printed versions or emailed versions or app versions, depending on how your patients learn. And one of the beautiful parts of rehab programs is that they actually prevent kinesiophobia. Because what's going to happen with your patients is that when they squat and it causes their knee to hurt, guess what they don't want to do when their knee starts feeling better? They don't want to squat, as they shouldn't. They're used to hurting when they do that. So what we need to do is we need to slowly get someone back into their rehab program. So I did find a cool article in Sports Science for Health in 2024 that talks about this. How do we start to bring someone back into rehab? And what is said is that we really should start off with stabilization based exercises. You and I know that. And that's why we include those exercises in the program. That whenever we start with shoulder exercises or hip exercise or core exercise, what do we start with? We start with the isometric exercises. We start with isometric flexion and extension for the shoulder. We start with isometric shoulders or things for the hip, like a one leg stance. We start with isometric exercise for lumbar region, like the side bridge and the plank. So making sure you start with those low movement, high activity level of the muscles for those specific patients, because patients won't be just using the tissue that got injured, they'll be using all the agonists around that tissue to help build up strength and resiliency. And we really want to make sure someone starts moving quickly, because unfortunately, if they don't, they will start to be more and more deconditioned. Especially, I'll find with my knee and hip patients, they don't want to squat. They don't want to get on the floor anymore because it causes pain. So I found another article that I think is very interesting. It's one of Dr. Burleson's favorite nighttime reading. It's in Geriatric Nursing. It's in 2024. And what it talks about is knee osteoarthritis. And what it says is kinesiophobia positively correlates with pain, disability, and functional limitation, meaning your patients who believe that all squats and movements of their knee and getting off the chair are going to hurt them, they will just stop doing those things and they will live smaller and smaller lives, meaning they're not going to be playing with their grandkids. They're not going to be driving anymore. They're not going to walk around Disney World because they believe it's going to hurt. This is a vicious cycle. It takes you and I being able to coordinate care to get them out of their problem, regain joint range of motion, and then slowly, progressively get them back into doing those things and finding those pain-free range of motions. One of the greatest exercise that I use in chiro is called a double posterior lunge. It's essentially a supported double leg squat. This is a great way to teach your patients how to start to hip hinge, how to take a little load off their knees, still use their body weight, and get them into those ranges of motion. The glimmer in your patient's eyes when you can teach them how to do something pain free that's going to allow them to live a bigger life is dramatic. It's one of the reasons I love being a chiropractor. Now, number seven, proper load management. This is by far the most mismanaged piece of all musculoskeletal care. And I guess that's an opinion. That's not a fact. However, this is where I don't think we spend enough time. When I talk about progressive loading, though, you'll be gradually increasing load on a muscle or tendon. This does not mean strengthening, it means loading. And think about that. When you stretch tissue, just even passively, that's load. When you passively stretch tissue and then do a little end range loading after that, that's a little more load. If you do isometric exercises, if you do then concentric exercise, then you do eccentric exercise, that's all increasing that load on the tissue, and then, of course, increasing the resistance with those associated movements. So, one of the things I want to bring up is this isn't just stretching versus strengthening. This is finding the person, finding where they are right now, and then slowly increasing it. And what we know is that when you can start to exercise someone, and you cannot cause sharp pain. It does not matter what the condition is, they will start to get better when it comes to the musculoskeletal world. Journal of Shoulder and Elbow Surgery. This is another one from 2024. And they said exercise effectively improves physical and psychological health measures in partial thickness rotator cuff tears when delivered in a clinic or at home. However, exercise is more effective for activity, active range of motion, and pain catastrophization when delivered in a clinic. And this is an opinion also. However, they have a provider looking after them. They have a cheerleader in the room that's showing them that it's okay to be in a little discomfort. That's making sure they're doing their exercise appropriately. So make sure you're supervising at least the first day of exercise for your patient. The next piece, also in the journal Shoulder and Elbow Surgery 2024, is that one of the things they also need are words of encouragement. Words of encouragement go a long way. Push them through discomfort. Our job is not to protect them. Our job is to prepare them because we can't be there all the time to tell them how to do their exercise or make sure they do their exercises or do a stretch or what have you. It's to give them the resources to let them make those decisions for themselves. And I mean, eh, I always think about it this way. It's like telling all your 70-year-olds, hey, listen, Robert, when it is 32 degrees, just don't go outside anymore. When it is 32 degrees Fahrenheit, for for you international listeners, Fahrenheit is a unit of measure no one else in the world uses, nor knows how to calculate. However, that's when water freezes. So if you told all of your 70-year-olds not to go out because there's a potential of ice and you may fall, that's protecting them. How do you prepare them? You increase their balance. You increase their strength. You show them how to do a one-leg stance. Those are all things you can do as an evidence-based chiropractor. You can use a one-leg stance exercise in chiro. You can use Valais exercise. You can start to do clam exercises and bridge exercises to help build some resiliency and capacity in that person and help prepare them that if that were to happen, they can actually succeed in that task. So eccentric loading wins for almost every single musculoskeletal condition. I really think that whenever we think about musculoskeletal tissue injuries, that's an orthopedic diagnosis. That's the weak link. So we have to strengthen it. So I do use mostly eccentric stuff, and I try to find exercise that patients can do at their house or at their home and doesn't require a lot of things they have to buy. So one other little piece of this puzzle as far as eccentric exercises is it doesn't matter which tissue you're strengthening. There's a I put some notes in the bottom of this podcast, but there's some notes on Achilles tendinopathy, some notes on quadricep strength. It doesn't matter what the tissue is, start loading it. The one piece I will bring up is that I was looking at there's an In Healthcare 2023 article talking about the Alverson protocol for Achilles tendinopathy. And of course, as all of you know, in ChiroUp, we do this for all of our Achilles tendinopathy patients. It's 3 sets of 15 reps. Sometimes you'll see people at the 4 sets of 20 reps of calf raises. They're doing it daily, if not twice a day. That's good. That's great. And in fact, for my patients, it's all they need. However, I read a paper a while back from Thomas Schaud stating that this protocol is great. However, it also needs to be correlated with your patient's activity level and ability. Because if you have a marathon runner, they can probably do a little bit more. If you have Jerry walking around Target at 50 years old, he's probably okay with just doing 3 sets of 15. If you have, Madison, it was a 24-year-old marathon runner. She probably needs to do a little more because her capacity and her body demands a little bit more out of her. Finally, we're going to talk about injections. So this is a way to speed up healing. Now let's talk about this in two pieces though, because some of you are not going to approve of this next section. But realistically, the facts are the facts. That if you're looking for short-term pain relief, steroid injections work really well. I mean, even if you consider yourself evidence-based, it is an evidence-based treatment. Steroid injections work well for short-term relief of many of the musculoskeletal conditions that we treat. So we can't turn a blind eye and say, oh, injections don't work, because they do. However, they're a really poor treatment approach due to let's just call it the catastrophic effects on the inflammatory process, due to the psychological impact on the patient because now they're dependent on it, due to the long-term catabolic effects of the surrounding tissues. So while I said steroid injections are good for short-term pain relief, they're really bad for management of musculoskeletal conditions. And this isn't from me, this is from the research. Now, one thing I did find is that I was looking through chiropractic journals. In the Journal of Chiropractic Medicine, there's an article by Kinney, 2024, that talked about a treatment for lateral epicondyle pain or lateral epicondylosis. And they did find, once again, corticosteroid injections provide once again, the most short-term pain relief, which is what your patients want. However, we can do some other things to give them long-term pain relief. Exercise therapy works really well. Ultrasound, laser, shockwave therapy work really well. And they also talk about PRP injections, which I'll cover in the next section. However, these are long-term solutions. So making sure you understand the difference and your patients understand that yes, you can do an injection, but it doesn't fix anything. It still requires doing the exercise and strengthen that tissue to help improve that long-term care. Also, exercise. Shoulder and Elbow Journal, 2022. I had to go back just a little bit. I apologize. However, once again, they found that corticosteroid injections work short term. However, if you're looking for long term effects, then we really want to use exercises. And exercises work much better to help get that person out of pain and keep them out of pain because now you're strengthening that weak link. Now, all right, you guys ready? This is a different section in the podcast. I want to talk about a new type of treatment. This is a treatment that I've thought about that, in all honesty, I don't do. However, I'm going to start doing. I'm going to give it a try, and I'll let you guys know how it goes. And what it is, it was and I'm not a factor certified practitioner. Do I have any insight into their assessment and their treatments? However, I've seen a lot of videos and read articles by Dr. Todd Riddle, and I've always been impressed, one, with him. His knowledge is impressive. However, when they use the instrument during range of motion, I was always curious on that, on why they actually move the tissue under load and they're scraping it. Like in my brain, I was thinking to myself, man, that just seems like a lot. It seems like a lot of afferentation of tissue. However, there's a new paper that came out July 2024, Journal of Bodywork and Movement Therapies, and it concluded that myofascial release with eccentric resistance was more effective than myofascial release without eccentric resistance in improving pain, range of motion, and function disability in patients with Achilles tendinopathy. This is kind of cool. So I went in, and of course, I read the paper. We have a research team that goes through four people that go through on a monthly basis and have pulled out all these research articles. If you ever want to know where I get all my research from, it's just in that research review section at the homepage of Chiro. Every single article that I'm pointing out is from that section. That's all I need to look at because I don't need to go to PubMed. Someone's already done that for me. However, when I went on there, we link everything on there. When I went in the link and actually read that paper, it talked about exactly what I was thinking about, which I thought was really cool because let's see here. In fact, at the end, they said this. The results indicated that combined interventions significantly improved pain intensity, ankle range of motion, and reduced function disability compared to myofascial alone. And then this next sentence, a study on augmented soft tissue treatment, ASTEM, along with eccentric exercises is warranted. So they're like, I think Factor was just ahead of the game. I mean, these guys are realizing that we can now eccentrically load, go through active and passive range of motion while performing myofascial release and getting better results. So something cool. I just thought that was kind of neat. Something you can try whether you're doing active release or you're doing pin and stretch. Try to eccentrically load that tissue and see what the response is. I think it might be fun. All right. Final component of the podcast today, we're going to play the name game. All right. You guys ready for this? In 1980, that's when I was born. Oh, I was born in 82, I guess. In 1980, what were the most common male and female names? Top male name, Michael and Christopher. Top female names, Jessica and Jennifer. In 2000, it was Jacob and Michael. And then for female, it was Emily and Madison. However, here's where things get fun. How old is Karen? How old is Susan? Well, it turns out if you go back to the birth, but just Google this, that they're born in their 60s. In fact, two top names in 1960s. If you drop down into the 1950s and 40s, their names are Robert, their names are Charles, or if you see a Linda, a Carol, a Mary, if you see those names come on your schedule, you need to start thinking ahead. And why do you need to think ahead? Because you need to think about, do I need some more time with them? They're a little bit older. They don't move quite as fast. I love playing the name game. However, that's where it actually becomes fun because it's going to change your patient flow. You all know when you have an 80-year-old Charles walks in your office, or you have a 12-year-old Jameson walk in your office, it's a different flow. One of the things you can help improve that flow is to get their intake information first because you already know what you're going to hear from Linda. Linda's going to give you when her pain started 45 years ago. use the automated intake surveys within ChiroUp so you can already get their HPI. You could already get their disability surveys. You're already going to have the regional complaint. You're already going to have your OPP QRST before they even walk in the door. And then you can ask the questions that you really need to know. And then don't forget, once you're done with that, make sure you deliver the most important piece of the information that patient needs to get better. You're going to deliver their exercises. You're going to deliver their ADL modifications. In fact, I'm going to put a couple infographic links and details in this podcast that are going to help you deliver that information to your patients. Because when we can start to give our patients condition reports and we can give them infographics on how they're going to help themselves, it's going to significantly improve your clinical outcomes and, most importantly, patient satisfaction. So, like always, if you like a podcast like this, please share with a friend. If you want to hear specific information, kind of like this, and you want me to do a podcast on it, let me know. Email me, Brandon@chirup.com. This entire podcast was developed based on the question of subscriber. So I think this is kind of one of those fun ways that you can communicate with us and we can bring this information back to you. Let's keep the feedback coming. I really appreciate you listening to the whole thing and look forward to creating the next one next month.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.